Well, hello, everyone. Welcome to the Department of Psychiatry and Behavioral Sciences Grand Rounds. My name is Joe Caramelli, and I oversee Grand Rounds for our department. So for this academic year, we have a theme for the Grand Rounds series called Next Steps in Care. And there's a core group of us that work on Grand Rounds each week, including Samhara Braha, who does coordination and communications, and Mike Walker doing technology. We archive our presentations on the Grand Rounds website, where you can see past presentations. I want to acknowledge funding for our series from the Ripley Fund and from different departments and institutes divisions and institutes in our department, such as the Garvey Institute for Brain Health Solutions. At the end of the presentation, please complete the Grand Round speaker evaluation. I'll aim to put that into the chat box close to the end of the presentation so that you could fill that out. And you're always welcome to send me overall comments and feedback. And now I'd like to introduce today's Grand Rounds speaker and presenter, Dr. Dorothy Sitt. Now, Dr. Sitt is an associate professor of psychiatry at the Feinberg School of Medicine at Northwestern University. And Dr. Sitt actually trained in two areas, initially in family medicine and later in general psychiatry, and subsequently completed specialty fellowship training in psychopharmacology research. And Dr. Sitt provides clinical care and trains residents, fellows, and medical students throughout the department. Dr. Sitt has studied the phenomenology, pathophysiology, and pharmacologic responses of women in perinatal period, but has also investigated novel therapies, including bright light therapy for bipolar depression, and bright light therapy for adolescents with depression and individuals with depression and epilepsy. Now, today Dr. Sitt is talking about adjunctive bright light therapy for patients with bipolar depression, including results from a clinical trial that was published in the American Journal of Psychiatry in 2018. Now, I'll leave it at that for now and turn it over to Dr. Sitt. Thank you.
Thank you, Joseph, for the kind introduction. I'm just going to try to share screen. Okay. Yes, so today I'm going to go over with you sort of aspects about bright light therapy, applications in the treatment of major mood disorders, and particularly in the management of bipolar depression. What is bright light therapy? Bright light therapy is a natural low-risk intervention that's delivered with commercially available light boxes. They're, in general, more so made more affordable these days. It can be used at home, as you see here, or in your office environment. It tends to provide a more rapid, robust, and sustained antidepressant effect, indicated for the treatment of seasonal affective disorder, non-seasonal depression, and it can be very much useful in applications for patients who are depressed during their pregnancy. So what exactly is bright light therapy? It's a chronotherapeutic or circadian-based intervention. It's implemented to actually reset and amplify rhythms that have been disrupted. And one of the common ones that we deal with would be abnormal sleep-wake patterns. It can also improve mood symptoms, even in cases in which the disruption in circadian rhythms is not the primary cause. And what happens is that the hypothesis, the phase shift hypothesis, suggests that correcting phase delayed sleep can improve alertness and uplift the mood, thereby restoring functioning social engagement, which are problems that often the mood patients encounter. So what are some of the benefits or advantages of bright light therapy? It is highly effective for managing patients who have atypical symptoms of depression. So these are targeting symptoms of lethargy, fatigue, hypersomnia, excessive appetite, weight gain. It also has alerting properties. So this actually may appeal to patients who are really struggling with their medications causing sedation, or sedation is part of their illness. It sort of appeals to people who want to minimize their drug exposures, avoiding drug-drug interactions. It usually produces very, infrequent, intolerable or adverse side effects. And the dose is readily titrated. And intriguingly, I'm showing you a little bit of a cartoon on the alerting properties and what are some of the brain activation pathways that may be suppressed with photic induction, but we may not have as much time to talk about it right now in this talk. The adult literature that supports bright light therapy, really robust evidence to support the applications in seasonal affective disorder, which we'll talk about in a couple slides. Non-seasonal major depression shows great promise, depression in pregnancy also, and from our group and others, the use of light therapy for bipolar depression. Patients who have seasonal affective disorder describe the recurring episodes that onset in the fall or the winter and remit in the spring. So it happens in relation to a specific time of years, this natural sort of recurrence at a certain time and also resolution at a certain time of year. Summer hypomanic episodes are pretty rare. They are reported in 2 to 8% of patients. But as you can see here, the general population in the US, Canada, tend to report rates of seasonal affective in less than 1% to 2 to 3%. When asked on self-report, it can be as high as 10%. Frequently, we see patients have some syndromal symptoms. Intriguingly, adolescents and children may be more susceptible. Definitely, our patients with mood disorders are at higher risk. The American Psychiatric Association guidelines indicates that bright light therapy is the first-line treatment for SAD. The symptoms, as I said, they're often presented with atypical symptoms of depression. Patients are highly sensitive to changes in the photoperiod, meaning the reduced hours of daylight, increased cloud cover, lowered photic intensity in the environment. And on top of that, they may have a genetic predisposition, a sensitivity to diminishing levels of light. So patients may experience a reduced retinal sensitivity at low levels of light. Secondly, abnormal pupillary light reflex responses, both of which can result in impaired retinal signaling to the SCN, which is the center of the brain that controls and regulates our circadian rhythms. So the facial hypothesis suggests it's so the mechanism by which light therapy exerts the antidepressant effect is not fully known, but the seminal concept underlying this facial hypothesis suggests that some mood disorders, such as SAD, may be in part due to mismatch in the circadian rhythm and mismatch between the sleep-wake patterns, some of their behaviors, and the central clock. And what happens is that the patients who are susceptible to, to the mismatch in the circadian rhythms, they're related to the sleep-wake cycle, and those that are more tightly coupled to the endogenous circadian pacemaker. Patients are susceptible to the seasonal changes in the photoperiod, particularly to the delayed timing in the sunrise with respect to the clock time. And this results in a persistent lateness in their wake and their bedtimes. The sleep phase delay is particularly noted in depressed patients. And so providing a corrective intervention or manipulation by introducing morning light can actually promote a phase advancement in their circadian rhythm using bright light in the morning or even low dose melatonin in the evening to correct this delay. And so with earlier studies, in fact, light therapy was developed 30 plus years ago, and investigators examined light therapy using, lower levels of using light boxes at that time was technologically advanced, but produced lower levels of light compared against placebo units, and had patients use the lights for quite longer durations of time, for up to 2 hours, sometimes more. Found that patients, in fact, responded quite robustly. These are very small studies. They produced lower levels of intensity of light, conducted for shorter durations of 1 to 2 weeks to 3 weeks. Intriguingly, the onset of response tend to happen within the first 2 to 4 days, and a full response was seen within 2 to 3 weeks. As you can tell, the limitations of these earlier trials were brief in duration, small sample size, and they sometimes were including both unipolar and bipolar patients. Building upon this, some of the groups actually examined timing of light, and the morning time certainly may improve and reverse some of the phase delayed circadian rhythms. But intriguingly, when they examined the timing of light introduced in the morning versus the evening, both groups seemed to improve significantly. And the large remission rates as seen with morning light that produced 50% response and remission. In fact, 33% of patients also responded to evening light. And the intriguing piece to this was that sequential exposure, introducing light in the evening and then moving it to the morning, seemed to produce the largest amount of remission, suggesting that light therapy may certainly be effective. Suggesting that light therapy may be effective administered in the morning, but some groups of patients may respond to evening light. So building on some of the earlier studies, the Canadian group implemented a longer, larger, more robust clinical trial, set up an 8-week RCT, brought in almost 100 patients, and compared the outcomes of bright light therapy against treatment with fluoxetine. And found that, in fact, they carefully designed it so that the patients who were administered bright light were also given a placebo pill. And the patients who were given the active antidepressant at a low dose of 20 milligrams of fluoxetine were given a placebo light unit. Intriguingly, both groups responded equally as well. 67% responded robustly, and 50 to 54% of patients experienced a full treatment remission. The light therapy group experienced a faster response within 1 week. And the patients who were treated with fluoxetine actually reported more side effects, agitation, sleep disturbance, and palpitations. But as you can see in the graphic to the left, that the onset of response is really quite rapid. Within the first 1 to 2 weeks, the response is quite significant in both groups. And it carries on through the 8-week period. Given the promise that they saw with the SAD patients, the same group then developed the follow-up study and introduced light therapy for non-seasonal major depressed patients, conducting an 8-week clinical trial. This time they introduced light and compared it against the antidepressant in 4 arms. They used a combination of bright light therapy and fluoxetine, light therapy plus a placebo pill. The third group was given low-dose fluoxetine plus an inactive unit. And the fourth group was given a placebo pill and placebo unit. Intriguing, though, the 2 groups that experienced the largest effect were the 2 groups that received, that were randomized to bright light exposure. And the effect size is rather compelling. Compared to the inactive treatment, the effect size of 1 in the first group, 0.8 in the second group, and a very sort of low effect with the fluoxetine only. As you see here with the non-seasonal depressed patients, the onset of response usually takes a little bit longer. Within the first 2 to 3 weeks, we see that effect take action, and it does gradually build up through to the 8-week period. At the same time, other groups elsewhere were rather intrigued by the promise that beholden from the evidence in SAD patients that light imparted, and started to look at applications to subspecialty populations, particularly antepartum depressed patients who really have sort of less, at that time, sort of less options. Now we know that we can certainly treat patients with SSRIs. It may be more difficult if they have bipolar depression in pregnancy, but here they carefully crafted a study, an ABA design, which means that they sort of evaluated patients repeatedly at baseline through the course of light treatment, and then repeated the assessments after they withdrew from the light therapy. And what they showed is that after 3 weeks of treatment, actually, in fact, 50% started to experience a full response. At 5 weeks, more than 50% experienced remission, but the trajectory of response was far more gradual than what was seen in SAD, and actually kind of maps onto the slow onset of action as seen in antidepressants. We'll just go through the slide quickly. What we see here is that, in fact, when patients do experience sort of a in fact, this is where they started to describe sort of this transient hypomania that happens when certain patients are prescribed morning light therapy, and this actually reversed by decreasing the dosage of light. Others who are partial responders become full responders by upping the dose of the light. And because of the promising earlier findings, the group in Switzerland, led by Anna Wirtz-Justice, carried out a randomized double-blind placebo-controlled trial of light therapy in patients who had non-seasonal antepartum depression. In this 5-week trial, they compared 7,000 lux of white light against dim red light. In their analysis, they sort of looked at a more pristine, more sort of peer group of completers, so they're not necessarily representing the generalized population, but here they do find that light therapy was very effective. Sort of the separation effect happens at week 3 to 5, significant difference at week 5. But even if you were to sort of look at the analysis with all the patients who are randomized in an intent to treat analysis, which should map onto more of a general population, the effects are still highly robust. So you see in the chart depicted below, highlighted, when we analyze or actually reanalyze the data, the patients who, all of patients who are randomized, we found that the rates of response remission were significantly greater with bright light compared to dim red light. Intriguingly, if we looked at the data using endpoint analysis only in the top 2 rows, you'll actually sort of question the efficacy, because the efficacy of dim red, which is a placebo, was rather high. In fact, it reached almost 45 to 50% responded to the dim red light compared to 81%, which is also very high, to the bright white light. So there's probably some advantages and disadvantages to using an endpoint analysis versus intent to treat analysis, especially in cases like these. And we can talk about it a little bit later if you want. So this sort of brings us to, bipolar disorder. It remains, I would say, a major public health concern. The prevalence of bipolar disorder is 1 to 2% of the population, but 4 to 6 actually may have bipolar spectrum illness. Often patients suffer from recurrent episodes of major depression, far more often than mania. They are at high risk for suicide, for suicidal ideation and completed suicide. Often struggle with comorbid and concurrent psychiatric conditions, including anxiety disorders, alcohol and substance use, eating disorder, impulse control, and ADHD. They often have to combat medical disorders as listed here. And the treatment options for bipolar depression still remain very limited. Gary Sachs' paper published in the New England Journal of Medicine suggested the response rates were really in the range of 32 to 38%. With mood stabilizer and even with mood stabilizer and antidepressants. And we know that antidepressant therapy in bipolar patients is not ideal. It can produce rapid cycling, manic induction, and more difficult to treat illness. Intriguingly, because I'm now sort of working in collaboration with some of the groups, the pediatric and child and adolescent psychiatry patients, providers, on a new study, it sort of became very much more aware of the importance of patient preferences and how that plays a role in treatment outcomes, in adherence. And we'll talk about it in adolescents later, but in adults, when I looked at the literature, when adults are interviewed, the depressed patients usually prefer things that can help them improve their ability to cope, which suggests psychotherapy, maybe some psychotherapy skills building. And adults with bipolar type 1 disorder interviewed in focus groups, albeit small reports, suggested they preferred treatments that were efficacious, that can help them sort of smooth out their highs and lows, and that can actually provide them with some clarity of thought and action. So sort of a more well-rounded understanding of what their preferences are. And more recent studies have shown that some of the positive attributes of the bipolar treatments would be ones that produce the least amount of metabolic side effects. So less weight gain, less sedation, impact on their sugars and their cholesterol. They don't cause them to feel manic, and hopefully the medications will work effectively and they don't have to wait too long for it. So because of this, we're sort of thinking, well, why not a novel somatic treatment such as light therapy that can be adjunctive, non-drug, but still somatic. And for this reason, we years ago, we were awarded a Stanley Foundation grant that went to Dr. Wisner, my mentor, to examine light therapy as a potential treatment option for women who have bipolar depression. And we enrolled 9 patients. This was designed as a dose-finding safety and preliminary safety and efficacy trial with a placebo lead-in. We used a light unit that was specially devised for these patients. They were not routinely available, but 7,000 lux of bright light. We enrolled patients who were on stable mood stabilizers, lithium anti-epileptic drugs, or an antipsychotic was approved. Placebo lead-in listed here. It gradually built up the dose. After the 2 weeks of the placebo exposure, the dose of morning light, which was adapted from the seasonal affective protocols, started at 15 minutes. We gradually built up every 2 weeks to max dose of 45 minutes. So we found that the onset of response for patients who did respond usually happened at 2 weeks. However, with the morning light, we ran the first 4 patients. 1 patient experienced a full response. However, 3 out of the 4 actually experienced a mixed or hypomanic response. And because of this high rate of manic induction or manic switch, we actually had to report this to the IRB, sort of temporarily put a stop to it, and try to reconfigure the protocol, because sort of producing this high rate of adverse mood effect was really not desired, and potentially presenting a higher risk to the patient. So we convened a group of experts in light therapy, and we went back to the literature to take a look at what had others done. We certainly paid attention to this impressive response to the timing of light therapy that can certainly produce response at midday or in the evening. And in fact, a group at NIMH who at that time, they still had a chronotherapy program that closed for a bit of time and has restarted now. At that years ago, they had actually set up an intriguing study for rapid cycling bipolar patients and examined bright light therapy that was timed in the morning, midday, and evening, and found that the morning, in fact, sort of mapped onto the same observations that we had, which produced a lot more agitation and some mixed symptoms. The midday group actually produced a smooth response, and the evening group produced some efficacy, a calming effect, but not as robust. So given the evidence from the literature, from our review, and also from talking with experts, we elected to sort of change the protocol, move it to midday exposure, and ran 5 more patients. Of the 5 patients, none of them experienced a manic induction. 3 had a full response, 1 a partial response that became a full responder, and the 5th one did not experience as much of a response. So you have a little graphics here. But given the promising effects of midday light in our case series, we decided to go ahead and apply for funding and received support from NIMH through career development work, T23, to support the work that I did here, which involved setting up a randomized controlled trial. It's a double-blind parallel placebo-controlled trial comparing bright light therapy, the bright white light exposure versus dim red, which we used in the case series, timed at midday. Here we would enroll patients. I'll talk about eligibility in the next slide, but here we amped up the light therapy on a weekly basis rather than a 2-week basis. We increased the target dose up to 60 minutes a day. The remission and response rates or response criteria defined here. We also defined mood polarity switch, and we were measuring both depression outcomes and mania rating scale outcomes every week, along with suicide ratings using the SSI, the safety ratings for side effects and functioning. We checked adherence carefully. We can talk about that later. We sort of had our light boxes configured in a way so that we could assess the illumination and use of light on a daily basis. We also implemented adherence strategies whereby the patients would reach out and call us daily or use a text to inform us they were using the light daily. And so we implemented a lot of strategies to improve the adherence. We enlisted women who were adults, men and women, bipolar 1 and 2. We looked at the frequencies of that. Patients needed to enroll with a moderate to severe level of depression, no or minimal hypomanic symptoms. They're on stable dose antimanics. We brought them in if they had concurrent antidepressants, they were stable. Being pregnant or postpartum was not an exclusion, but we had to exclude patients who had psychosis, who were imminently suicidal, who had OCD, uncontrolled thyroid disease, active use disorders, and other problems related to photosensitizing drug exposure or some eye disease that would impact their absorption of light. And so here's a description of our randomization design. And protection of the blind is actually very important in a treatment that is visible. So we separated the team, and really important to mitigate expectations that are sort of might skew the results. Limit the risk for allegiance or nonspecific treatment effects. So the units, we had separate teams who were blind and non-blind, personnel who would interact patients and separately from each other. The units, the light box units appeared identical, they kept in sort of unmarked containers. We had the clinical or blinded team review mood ratings only, and they would not be informed of the side effects, the response, the dosing, so that their clinician rating skills would not be contaminated. And also, we actually enlisted the help of patients and their clinicians to, come into an agreement that they won't search and try to find more information outside of the study until afterwards, at which time we would provide them with plenty of education. So here's an example with the light box that we used. It's a 4,000 Kelvin. So this is a kind of a cooler light. It actually produces kind of like a blue enriched. It's a bright white light box, but it's a little bit blue enriched. It's definitely safe, UV block, so there's no damage to the eyes or to the skin. The dimensions are probably 12 by 13 inches. People are asked to place it on the stand, so it's eye level. The optimal placement. The light is constructed in a way, the unit's constructed in a way so that it provides a diffuse lighting, meaning that you can't see the light bulbs in the back. And that really is important to reduce the amount of glare and discomfort. So the stats analysis are here. So results, this was a study that required a fair amount of effort. We did a lot of phone screens. We were able to screen out many of the ineligible patients without having to bring them in. We brought in 90 patients for baseline visits. Again, many had to be excluded because they were either rapid cycling, hypomanic, they may not have been on medication treatment, or their depression scores were too low. The demographics are as follows. So what we see here is pretty standard. We brought in a majority of patients were middle-aged, more women than men. Given that we were based in the University of Pittsburgh, Southwestern Pennsylvania, the racial distribution is as follows, matching where we were studying at. Educational level shows that people had maybe some groups who had some graduate professional education, but many did not. And same, which matched with their employment levels. And the clinical characteristics, intriguingly, even though bipolar depression is more prevalent in bipolar 2, we actually enrolled more bipolar 1 patients. Many of the patients, as we interviewed, and which is not surprising, I'm sure, to many clinicians, is that their age of first episode was actually as an adolescent or even as a kid, as a child. Many, many years of illness, almost 30 plus years of illness, often experienced depression as their first episode. Many were experiencing metabolic and other medical conditions indicated by their BMI, which is very high. And the majority actually were treated on mood stabilizer and antidepressant. And at the time of randomization, as you can tell, patients in both groups had moderate to severe levels of depression. Maybe 20 to 25% had some level of suicidal ideation. Their functioning was very low. Some of the patients had a degree of seasonality, but not everyone had winter depression. In fact, as you can tell, it's a little bit more of an intermediate level, and same with their chronotype. Some would suggest the intermediate morningness, eveningness questionnaire would suggest that they had representation from both people who were more morning larks as well as night owls. In general, in both groups, they often complained of poor sleep quality. Even though we, randomized the patients in a blind fashion, what you see here is that despite our efforts to randomize, we still sort of had some differences in the baseline characteristics between the active and the inactive light group. So the levels of depression were a little bit more severe in the inactive light, and the level of functioning, again, was a little bit worse off in the patients who were randomized to dim red. At time of year enrollment often get this question. In fact, we actually had 30–35% of people enroll in the spring and the summer, and the rest came into the study in the fall or winter. Follow-up visits were very good. Many of the patients in both groups were adherent to treatment, adherent to the light dose. They were able to reach their final target dose. One person exited early in the active and 5 in the inactive. Even so, the difference, it looks big, but it was still not significant. So what were the primary outcome findings? So we found that the rates of remission were significantly increased in the group that was assigned to bright light therapy. 68, almost 70% remitted with bright light, 22% remitted with the non-active light. And the effect size was significant and different. The SIAD's depression score also showed a significant difference between the active and inactive light. The patients who were assigned to bright light had low levels of depression. In fact, almost, many of them remitted, whereas the patients who received the inactive treatment, experienced mild levels of depression at the final visit, which still is an improvement, but not as good as the active, not as good as the group that received the active treatment. And functioning, which is highly important in our patients who have bipolar depression, showed significant differences in the active versus the inactive. So in summary, what we found is that light therapy at midday as an adjunctive treatment is efficacious, provides a potent and stable effect within the first 4 to 6 weeks. We really were not able to sort of study a maintenance treatment or find outcomes related to that. But the rates of remission, the lower depression scores, and higher global functioning suggest that this is a very promising treatment for bipolar depression. That plus no evidence of sort of manic switch with this type of treatment, especially when patients are maintained on an anti-manic therapy. So what are some of the factors that might have prevented this manic switch compared to the first study? Well, we used a dose titration approach in both, but the timing of BLT or bright light therapy was different. We used it at midday. Definitely having patients stay on and initiate anti-manic therapy before adding in light is critical. But what are some of the concerns? Well, we haven't yet been able to replicate. We not been able to get funding to do this yet. We compare to other groups, for example, Dauphinus and Rosenthal et al. They introduced light therapy in the morning, conducted an 8-week clinical trial, and found, in fact, robust responses in both groups, in both the morning light and also with their placebo comparator, which sort of makes us wonder, could their placebo unit have produced some type of treatment effect? Morning timing, a longer duration trial certainly could pose maybe relevant factors and explain the difference in outcomes in theirs compared to ours. The expectations of treatment with the light therapy were pretty similar in both groups. Often we get sort of challenged on, whether or not the people who were given the light box that was less active, not active at all, would have a different expectation. And yet when we looked at it, repeated measures at week 0 and week 6, we really did not see much of an evidence of this playing a role in their outcome. So what I'll do is I'm just gonna, we have maybe 20, 25 minutes left. So I really would like to make sure we kind of get to some of the more practical applications to how, to inform clinicians on how to introduce light therapy into their clinic, into their, bring it up with their patients. And then after that, we might talk a little bit, if time permitted, we can talk a little bit more about sort of upcoming studies. What have we done since publishing this clinical trial? So in general, how to select and set up the light box for your patients. So we usually would advise a patient that clinicians select a light box that is broad spectrum white light, that is 7 to 10,000 lux, that's equipped with a diffusion filter, setting it at a 12 to 14 inches distance. And the light box needs to provide sufficient illumination. So in the past, manufacturers produce very sort of attractive marketed smaller spotlights. And if people decided to purchase those, they would probably need to buy a whole bunch of them and set it throughout their room, or, try to map it onto the larger light box units, which usually measure 12 by 14 inches, as you see depicted here. So during light therapy, they need to set the light unit at eye level, downward tilting, to avoid direct exposure to the eyes. Eyes should be open while using the light, but avoid directly staring at it. So you usually encourage to use the surface in front. The parameters for light therapy, as we talked about, usually for SAD, we would suggest using it in the morning, selecting out a 10,000 lux light box, using it daily at the time of awakening. Likewise with non-seasonal depression, and also with pregnant women who have major depression, the ideal timing of light therapy is probably in the morning. With the patients who have bipolar depression, we would suggest starting the light therapy at midday, amping up the light, so starting at a lower dose and gradually building. And once a person has, been using it for at least a good 4 to 6 weeks and have experienced maybe a response or a partial response, not quite a full response, at that time, one may choose to suggest moving the timing of light from the midday to morning. What are some of the side effects to remark on? Important to indicate observations for agitation, to observe for agitation, irritability. Commonly, patients may report a little bit of headache, eye strain, nausea, some disturbance in their sleep. If this happens, what are some of the strategies? Mainly to reduce the light dose or the time duration of using the light. In some instances, it may be important to stop and then re-challenge at a lower duration or dosing. Oftentimes, we may try to individualize the protocol, especially if patients are having significant problems with their sleep-wake pattern. If they are very phase delayed, the tendency to go to bed super late after midnight and wake up sort of in the middle of the day. This is probably a time when you may want to have them start using the light at the time that they naturally wake up, and gradually bring the timing of their light therapy to an earlier time point in the morning to help them not only improve their depression using morning bright light, but also to gradually phase advance their timing of their sleep wake. For patients who have non-seasonal depression or SAD and getting partial response, adjunctive antidepressant therapy such as low-dose fluoxetine would make a lot of sense and evidence-based. With bipolar depression, as what we had said, it'll be important as clinicians to monitor carefully for manic induction, especially in the first 4 to 6 weeks of treatment before they've been able to see a full response. If it happens, then you may need to reduce the dose for a period of as indicated here, advance by smaller increments, possibly stop, add in low-dose sleep aid, and consider adherence strategies. Sometimes people can sort of refine their understanding of their sleep phase or their circadian phase by completing, by estimating their chronotype. And one helpful instrument is the Horn-Osberg morningness, eveningness scale. Completing this and scoring it is rather difficult as a clinician, so I would reference the website cet.org, which stands for the Center for Environmental Therapeutics, they actually have an automated MEQ. Doing this will help the person estimate their actual clinical chronotype and then use that information to decide upon the more optimal timing of the light therapy. What are some relative contraindications? Really not many, mainly related to medical conditions that increase photosensitivity or taking treatments such as medications that can increase their photosensitivity. Certainly light and melatonin can be used optimally to sort of help to reset or phase shift if needed. So that's not necessarily a contraindication, except when we're running a clinical trial. So assurances that the safety data are in support of using light therapy, bright light therapy, the one that we're talking about, the sort of broad spectrum bright light, really encourage people to avoid selecting out full spectrum units that produce ultraviolet emission. And also trying to sort of understand that the mono wavelength lights, blue light, green light, are sort of produced in various newer devices, marketed heavily. We still don't have tons of safety data on it, so it may be important to take a second look at this. We have, let's see here. So it's 2:40. So okay, 2:40. So maybe just a couple minutes to talk about next steps. We did, and I'm not going to sort of go over this here, but as a follow-up to the K23 award, we actually got funding from NARCET, or the Brain Behavioral Research Foundation, to look at light effects on the visual system, the neurological and electrophysiological responses. I'm not going to talk about that here because I really wanted to focus more on the clinical applications. And what we are going to be doing, which we are now doing, is we have a pilot grant from Northwestern, the New Cats program, which is supporting a study on examining light therapy for outpatient adolescents who have major depression. And we are working in collaboration with their primary care pediatricians to examine this as a potential option. The problems with depression in adolescents are as follows. It often presents in the pediatric primary care settings. Light therapy has been studied in very small groups of adolescents, mainly on inpatient units, and so it's not really generalizable to primary care settings. Moreover, when patients are detected to have depression, the primary care pediatricians often have varying levels of comfort in prescribing medications, including SSRIs, and likewise with the family members. In fact, the family members may be more inclined to referring them for non-drug treatments, such as psychotherapy, as a first line. So for this reason, given the robust somatic effects, we wanted to take a look at the applications of light in adolescents. And so there's a 5% rate of depression, maybe higher, and 14% screen positive in primary care. Clearly, psychotherapy is effective. It's effective in 65% of adolescents with depression, as with SSRIs. The combined treatment is certainly impressive at rates of 86%. However, whether people can have access to skilled therapists or to knowledgeable prescribers who can prescribe SSRI, it's not really clear, maybe less so. Preferences for treatment among adolescents, really they tend to prefer psychotherapy options or some kind of psychosocial intervention over drugs. Same with the parents who provide maybe a combined treatment approach. Older adolescent females tend to prefer combined treatment. So this is why we wanted to take a look at this light as a potential option. The literature is compelling. I mean, there's some trials that are suggesting that it can be effective, but they're limited. Smaller samples, mainly on inpatient, and they did not necessarily sort of report on the light intensity of the units that were used and how long the patients used the treatment or were enrolled in the treatment. So for that reason, we're bringing in patients who have a screen positive of depression in their pediatrician's office, confirmed on diagnostic interview, and also we'll be enrolling patients who have a moderate to severe level of depression. So this is going to be sort of patients who are difficult to treat, may not naturally sort of have a resolution without treatment. We'll explain bright light therapy to the patient and their parents, monitor carefully their mood symptoms using online self-rated instruments. And on top of that, we'll be assessing their activity and sleep-wake levels using ActiWatches. Ideally, the patients will be seen by us virtually every 2 weeks. We will adjust their dosing, mapping onto our case studies. In women, we will be starting with the 10,000 lux light in the morning and gradually building the dose across 6 to 8 weeks, monitoring carefully for manic and mixed symptoms. So the hypotheses, we actually also built in sort of a careful exploration of their preferences using a focus group approach. We call it the Sharps panel. It's sort of adapted, I think, from a Picori format. But we will be sort of understanding, we actually completed their interviews, adjusted our protocol to match with their needs assessment. And we will be assessing very basic outcome measures, ensuring adherence is adequate, so at least 80% are able to adhere to the prescribed treatment, that the treatment is tolerable, and we'll be measuring side effects carefully, that the mood scores will improve, and that their general functioning, the clinician's impression will also improve. So this is, I'm just going to sort of stop here and maybe allow for questions for the Q&A. Maybe Joseph can take over that and lead any questions if he has. I just want to make sure that you see my disclosures and acknowledgement.
Well, thank you, Dr. Sitt, for walking us through the background on bright light therapy and different disorders, your rationale on moving towards bipolar depression, the need for really new treatments and care in individuals with bipolar depression, and results of that trial, what you're working on now in a new population. And I'd like to encourage others to write in questions and comments. It is, one of the questions that came in right away was if, in general, you tend to favor fluoxetine specifically. And I wonder if that question means combined with bright light therapy or just in general.
It's a very interesting question, because we do sort of have older data that suggests that light therapy can map onto the serotonergic system. And so it would make sense that we would start with, an SSRI to bolster the response. And why did they select a low dose fluoxetine? I did ask the investigators on that, and they said that they wanted to select a dose that would produce the least amount of side effects, that was tolerable and also efficacious. And in fact, what I see more impressively is that the patients who are maintained on lower dose treatments, lower dose SSRIs, really can't up the dose any further because of intolerable side effects. And that's where they experience a partial response, they need augmentation, and we do sort of add in the bright light, and it can be super effective. It's this is based on the clinical experience. Do I go with fluoxetine? Really depends on what the patient preferences, what their experiences. If fluoxetine has provided a good response in the past and they're looking for a little bit of an augmentation, that I would go with it. But other SSRIs are probably fine. But I definitely would suggest starting with the lower dose of the SSRI and gradually building if they're using it as a combined treatment.
Now, one follow-up question I was wondering about, in the clinical trial of individuals with bipolar depression, I was struck that the majority of participants were receiving treatment with an antidepressant. Do you think that influenced your results?
Sorry, can you just say that again? I'm
Yeah,
trying to
there,
not, I'm trying to read the chat and then I think it's
of course.
blocking my
Yeah.
slide here. Okay.
Yeah, I mean, that the bipolar depression trial, more than half of people were receiving treatment with an antidepressant. Do you think that influenced your results?
Oh, how might it have influenced? So we were very concerned that could pose an impact on the outcomes. We were concerned that it could produce more of a risk for adverse effects, the risk for manic induction. And to get around that, we actually stratified. So we used a statistical, or we used a procedure where we ensured that equal numbers of people were stratified and assigned to light versus the inactive treatment, so that there would not be sort of an imbalance. And if there was an adverse outcome, it wouldn't be because we had sort of an imbalance in the numbers of people who were on antidepressant in one versus the other. It didn't turn out to be a factor, but it was probably very important for us to do, given our concerns that, you know, people were flipping because of this exposure when they were randomized to the morning light at that time.
Thank you. And Dr. Said, another question came in about bright light therapy in other clinical populations, such as individuals with ADHD or negative symptoms in schizophrenia. Has this been explored, or are you aware of?
Yeah, no, the question about ADHD is very interesting. And because it can improve the alertness and attention, we're trying to combat, you know, struggles with the focus, concentration in the ADHD patients. Certainly, I've actually used it. There are earlier pubs that have found it to be promising. Not as much follow-up data on that, but it's definitely an intriguing option. I think that we need more studies to build on our understanding and to have the evidence to prescribe it. Negative symptoms for schizophrenia is a fascinating question. I didn't think of it, but it certainly can be. Who knows if it can prove helpful? I'm not sure what the origins of the negative symptoms are. Certainly, you know, who knows if it may improve the sedating effects of the medications that we're prescribing. But I would like to sort of maybe build on that a little bit more and sort of come back and think about it and talk with you all about that option. We actually excluded people who had psychotic disorders of primary illness because of the concern that we just didn't have enough information. We're concerned that it would produce worsening agitation. But maybe there can be important indications in subgroups of people who do have schizophrenia. So that's a really nice question to ask.
A question about the device itself, or the light box. Can you help me understand? I can appreciate fluoxetine 10 milligrams, 20 milligrams differences in doses. I understand that very clearly. Tell me about 7,000 lux versus 10,000 lux. Is there low dose? Is 7,000 lux low dose? Might we start that with some people and advance the 10,000, or is that just a range that we're looking for?
Yeah, I would say that for groups of people who your concept is that they may experience a sensitive response if we just don't know or have enough information in that population, as we did with the as you know, our colleagues did with the perinatal patients, with the bipolar depressed patients. We certainly started with the 7,000 lux, and we actually were able to see robust responses in all of those groups of people. So it may be that 7,000 lux is sufficient for certain groups. You know, I think that with our adolescents, we are going, you know, full on with the 10,000 lux. But if we discover that the level of side effects and intolerability is too high, we may need to dial back to 7,000.
And is there?
Yeah. So the light boxes are manufactured, I think, so that people can use one or two settings.
Oh, I see.
Yeah.
And that actually, someone asked a question about recommending a specific light box, perhaps the one you use in trials, or even that you use clinical. I know it's a question I'm asked in clinical settings.
No, there's a really nice publication from just a couple of years ago, and I think we saw their poster data at the society, at the SLTBR, is very carefully constructed study, and they examined the equipment from many, many manufacturers, and found that so using their objective approach, sort of unbiased approach, they found that boxes that were produced by the Sunbox company, I'm just saying this in no particular order, but the Sunbox company produces a very effective, sort of sizable light box that can be used. The group that the Northern Light Technologies also produces another very good unit. And then the group that we used, the Daylight Classic model, which was manufactured by a small company in Canada, but now it was bought out by Carrick's Compass Health brand. They also produce, the light box that we have in our study. But I really don't want to sort of guide people on, where to get their light boxes. But I think the website, the nonprofit group cet.org, which is listed here, does provide a fair amount of information on that. And I think going to that site, also looking at the paper, which I might be able to find and just send to you, Joseph, so you can share with others, very helpful information on how to select the boxes.
Thank you. That's helpful guidance. I'm aware of that paper. I believe it's in Psychiatry Research and Clinical Practice, the newer APA journal.
Yeah.
Another comment came in from Dr. Aaron Green. Perhaps dose changes is not just related to the amount of lux, it's related to timing of administration, moving the different times of the day. That's another way to think about it.
Yeah, so that's where we sort of can use light and sort of individualize the protocol for each of our patients based on, a very careful survey of their, their chronotype or their morning evening preference. Definitely, we would not suggest asking people to wake earlier than their regular wake time. To use light therapy, would never ask people to do that. If they're using morning light, the best is to time it in the morning at the time when they do wake up, and then gradually build it, bring it to gradually bring the timing of light to an early time. If the target is to sort of not only improve their mood symptoms, but to help them phase shift a little bit and get their circadian phase a little bit more matched with the night day schedule or with their school or office schedule.
Well, Dr. Sett, we're here at 1 o'clock, and I want to thank you again for presenting to our department in the Grand Round series. Thank you again, and a note to attendees that this will be available on the Grand Rounds website in the archive as well. But thank you, Dr. Sett, and we'll end there.
All right, thank you so much, Dr. Sarah-Mells. Great to be able to talk with you all about this.
Thank you.
Pleasure. Thanks. Bye.
Bye.